Now it's time to talk about tumor nomenclature. How do we name tumors? So, like we just said before, there's benign and malignant types of cancers, and that determines how we name them. So benign cancers, what do they end in? What is the suffix that they end in? And malignant, what do they end in? So benign end in oma, and generally just oma, nothing before that oma, like we'll see with malignant. Malignant, in general, depends on if it's derived from epithelial tissue or mesenchymal tissue. If it's from epithelial tissue, what do they end in? What's the suffix? Carcinoma. Very good. What about mesenchymal tissue? Sarcoma. So that is a very general rule, and most of the time it holds true. So keep that in mind, and you'll be able to name almost any cancer and figure out where it's derived from. So let's get some practice. So let's start with some epithelial types of tissues, and we're going to go through, there's a benign counterpart to epithelial tissue, and there is a malignant counterpart. So here is a polyp in a colon. What is this called? It's called a tubular adenoma. It sort of resembles a strawberry on a stick, and they are benign, but they're also pre-neoplastic, so you got to get rid of them. That's why we have colonoscopies at what age? What age do they start? Age 50. Very good. All right, what is the malignant counterpart to these tubular adenomas? Here's what it looks like. This is full-blown adenocarcinoma. So the carcinoma implies from epithelial malignant tissue. Very good. And you can see here that it's necrotic, fungating, and in general very ugly, as opposed to the benign tissue, which is circular, circumscribed, and well confined to one area. So that's how you can differentiate, in general, benign and malignant tumors. And also a very general rule is remember the M for malignant. Remember that M stands for metastasis. Anything that metastasizes is malignant, for all intensive purposes. All right, how about blood vessels? What is the benign counterpart to blood vessels from endothelial cells? Here's a common USMLE question. It'll ask about a kid who has these lesions, and then it will ask what's the next best step in management. First of all, what are they? Capillary hemangiomas. And what's the treatment? Nothing. You just watch them, and they will spontaneously regress over months without any scarring. They'll completely go away, completely fade away. Well, what is the malignant counterpart to capillary hemangiomas? Angiosarcoma, such as we see in the liver when someone's exposed to what types of agents? Vinyl chloride, arsenic, thorotrast. VAT. We'll talk about that a little bit later. So that's angiocarcinoma. It's from epithelial malignant tissue. All right, what about smooth muscle? What's the benign counterpart to this? Give you a hint. It's very common in the uterus of almost more than half of women, and it's a common cause of irregular bleeding. These are called, the common term is fibroids, but the correct term is uterine leiomyomas. Okay? What's the malignant counterpart to this? Well, we said leiomyoma. Let's just add a leiomyosarcoma. So add the sarc to it, and we have malignant. Finally, let's talk about bone. What's a benign outgrowth, a little nubbin off of a bone? This is just called an osteoma. Osteoma, from bone, benign growth. Just chip it off, easy removal. What's the malignant counterpart to this? You'll see it in a kid who has knee pain, maybe an adolescent who's in football practice, fractures his lower part of his femur after just a small hit. What's this? You see a sunburst appearance on X-ray. Codman's triangle. This is osteogenic sarcoma. Very good. What's the mechanism, or what's the gene associated with this? The RB, retinoblastoma tumor suppressor gene. Very good. So again, we have benign and malignant types of cancers. But what are the fundamental differences between these two types of tissues? Let's start with benign first. What are the characteristics of benign tumors? Well, they're slow growing, okay? They're round and symmetrical. They're often surrounded by a fibrous capsule. And remember what I was saying about desmoplasia and how whenever a type of cell is growing too much, that the surrounding cells are going to try to inhibit it with what cytokine? TGF-beta. Well, once again, this TGF-beta might stimulate some fibroblasts around here, and they might synthesize collagen that leads to this fibrous tissue that's associated with cancers. Okay, so those are benign. They're just sort of nice, neat looking, as opposed to malignant, which are not. They're irregularly shaped, necrotic, ugly, fungating masses, often with bleeding and hemorrhaging and other nasty stuff. And the most important thing, like I said before, what is it? The M of malignant stands for metastasis. They can spread. They're dangerous and deadly. As we see it metastasizing here. Ooh, scary. All right, let's now briefly talk about cachexia. So, cachexia, what is it? And what does it do to? So, very briefly. So, here we see, wow, a very wasted away patient with terminal cancer. And this is how often patients appear. They're often very thin, wasting, and gaunt, despite however much nutrition they're given. This is called cachexia, and it's due to chronic inflammation associated with cancer and the release of certain cytokines. Do you remember, or do you know, what is the specific and most associated cytokine with this condition? Tumor necrosis factor alpha. Also, you'll see interferon gamma and interleukin 6 around too, but particularly TNF alpha is associated with wasting and causing cells to just waste away. It induces apoptosis, actually. So no matter how much nutrition you give them, they're just going to keep losing weight. All right, now let's talk about some disease conditions associated with cancers. The first is this one. So this kid has a flat nose and upward slanting eyes, a protruding tongue. What do you think this disease is? What does this poor kid have? Down syndrome. All right, and now what neoplasm is associated with this? Acute lymphoblastic leukemia. And the way to remember this is that we all, ALL, we all fall down. Down syndrome. Good. So know that one, pocket that away. What about this disease? What do you think this poor girl has? So she's very sensitive to sunlight, as you can tell by her sun-damaged skin, and she has extensive freckles and sunburn. So we know that she's sensitive to sun. What disease do you think she has, and what is the underlying molecular problem? So we think she has, what? Xeroderma pigmentosum. And what's the problem here? The problem is with DNA excision repair, especially after exposure to UVA and UVB light. So the light comes in and it alters the DNA of the skin cells so that there's pyrimidine dimers formed, and these individuals are unable to excise and repair these pyrimidine dimers, so they run the risk of skin cancers. Well, what types of skin cancers do you think they're at risk for? How about melanoma? One of the most deadly ones. And how do we know that this is a melanoma? Well, recall the A, B, C, D, E criteria. So the A stands for asymmetry. This is asymmetrical, right? Yes. B, border, ill-defined borders. Some of these borders are sort of fading in to the outlined skin. C, color. There's a bunch of different colors here. There should only be one. D, the diameter. It's a large diameter, greater than 5 millimeters. That's too big. And E is evolving, so changes over time. That's scary. You got to look out for the A, B, C, D, E criteria. Speaking of preventing skin cancers, the USMLE will often describe a precursor lesion to squamous cell carcinomas that's often found in the ear. We'll say like the ear or the arm of farmers. It'll be rough and scaly and erythematous in appearance. If the farmer scrapes it off, it comes right back. What is the name of this precancerous lesion? Actinic keratosis. Remember that. Good. All right. Here is columnar epithelium in the esophagus. That should not be there. It should be squamous. So this is Barrett's esophagus. Barrett's esophagus, recall, develops due to acid injury to the esophagus. So repeated exposure to acid and reflux from the stomach causes the epithelium to metaplastically change from the normal squamous epithelium to this columnar glandular epithelium to try to protect itself and coat itself with mucin. Remember, what's that called? I just said it. What's the name of that transformation? That was metaplasia. We saw it earlier. Where did we see it? In the bronchus of the lung. We talked about that. All right, so that's metaplasia. And remember, whenever we change from one adult cell type to another, we change the DNA of that cell. And changing DNA causes us to run the risk of cancer, right? Of neoplastic progression, because anytime you mess with the genes, anytime you mess with DNA, you could lead to mutations and cancer. All right, so that could cause what type of cancer specifically? Esophageal adenocarcinoma. Esophageal adenocarcinoma, because it's of glandular tissue, it will turn into a glandular cancer. All right, what's this? Ascites, right? There's a lot of fluid in this person's belly. What's it due to, probably? Cirrhosis of the liver. Fibrous tissue in the liver is preventing fluid from getting into it, and it backs up and leaks out into the abdomen. So that's called ascites. Good. So what are common causes of cirrhosis? How about chronic hepatitis infections like hepatitis B, hepatitis C, or chronic alcoholism? And all this chronic inflammation from hepatitis over and over again can predispose an individual to what type of malignancy? So all these free radicals around can actually damage DNA and cause primary hepatocellular carcinoma. And you can see this here in this singular necrotic mass that's enlarging here in the liver. So that's primary hepatocellular carcinoma. We'll talk about that a little bit more later. What about an individual with AIDS? Okay, I didn't have one specific lesion for AIDS that it presents with a number of things, so I just put up this ribbon here. But let's say a patient who has known AIDS with a CD4 count of 25, very low, presents with mental status changes, confusion, and motor sensory deficits. A head CT shows this. What is that? There's a ring-enhancing lesion right there. And first of all, what's the most common cause of a ring-enhancing lesion in an AIDS patient? Toxoplasmosis. Thus, you'd start them on treatment with what? Trimethoprim sulfamethoxazole. And if this toxoplasmosis is in their brain, then they will improve with treatment. But if it's not toxo, if it doesn't improve after antibiotic therapy, then you'd likely take a biopsy. And what would that biopsy show if you could take a little sample of this ring-enhancing lesion that's not going away with trimethoprim sulfamethoxazole? What is it? Primary CNS lymphoma. And how would you treat that? Well, you'd start them on antiretroviral therapy, increase their CD4 count, and use their own immune system to shrink the tumor. So that's what you do. And in general, anytime the immune system is disturbed, like in people who are immunocompromised or with autoimmune diseases, there is a significantly increased chance of developing lymphomas. And possibly because CD4 T cells are part of the process of fighting off lymphomas. So you need to have these around to keep them at bay. So that makes sense. All right, what about radiation? Radiation, what is this associated with particularly? Well, we already discussed how radiation hydrolyzes water molecules, right? Turns H2O into hydroxyl free radicals. Very dangerous free radicals. And these can go and bind to DNA and disrupt DNA proliferation and cause all kinds of mutations and eventually neoplastic transformation. So the USMLE really likes the association between radiation and specific types of cancers. What in particular? What is the one you should know? Papillary carcinoma of the thyroid. For some reason, it causes this. Also, leukemias, breast cancer, and other sarcomas too. So know those. Flash quiz. What cancer is associated with ulcerative colitis? What do you think? Lots of inflammation of the colon is going to lead to colon cancer, right? Adenocarcinoma of the colon. Good.